welcome friends, colleagues, partners, and all others to today's webinar on fNIRS and infant imaging. I'm so pleased to have the honor of opening things up today and welcoming today's speaker, Dr. Judit Gervain. Dr. Gervain investigates early speech perception, language acquisition, and cognitive development with a particular focus on infants at Padova University in Italy. I do apologize for my pronunciation of your name, Judit. Her groundbreaking research has utilized fNIRS as well as EEG in combination with behavioral methods to further our understanding of language development in infants and children. Our company, NIRx, is a complete fNIRS solution provider. Founded in 2000, today NIRx has over 850 active end-user labs worldwide, 20 distribution offices in both European and North American headquarters. Today, there's myself, Thomas Johansson, Dr. Mahipal Chaudhary, who will be taking questions during the webinar, as well as working on those and giving those to Judit later, and Lamia Pashalich, who is also helping with run everything's, working from the NIRx side. There are a few considerations that I'd like to go over. You are muted. Questions are welcome at any time. You can enter those in by typing them, and we will see them and be able to get to those as mentioned. Please use the GoToWebinar panel. Content will be available on our website in upcoming days as everything is being recorded. And if you have additional questions, please do reach out to us at consulting@nirx.net. Now let's get back to the topic at hand. Today we will all receive an introduction to infant imaging with fNIRS. Please do not worry if you have very little or even no experience with neuroimaging or fNIRS. Dr. Gervain will walk us through a number of key considerations, including general advantages and trade-offs of using fNIRS for developmental research, specific use cases such as looking at simultaneous parent-child measurements, practical considerations related to setup and experimental design. Infants can be tricky after all. So with that, I'd like to pass it over to Judit.
So thank you very much. I'm really excited to be here today with all of you, and I try to share whatever experience and knowledge I have of NIRS and how to do NIRS with infants. So here is the roadmap for today. I'm going to first sort of introduce you to the basic sort of theoretical questions that we ask when we use NIRS with babies. What are the kinds of things that actually you can use NIRS for? What are the kinds of research questions you can answer? I will then go on to have a few sort of methodological considerations. So as Thomas was saying, babies are indeed tricky. So how do you make the whole thing work if you have to work with participants who are not particularly compliant? And then I will go on to present a few empirical studies from my own laboratory to illustrate the point of how variable the infant hemodynamic response function can be and what you can do about it, how to interpret that. And I will leave you with a few review papers of NIRS, but also NIRS used for developmental work. Okay, so let's start off. Why do we use NIRS when we study babies? Well, why do we study babies at all? Actually, NIRS and in developmental research in general allows us to ask questions about babies. Why is that so special? Well, the most important thing is adults are relatively easy to study. You can ask them all sorts of questions or tell them to do certain things. But then how do you know where this knowledge or these abilities come from? And there has been a long debate going back really to ever since we have science, philosophy, at least minimally to sort of the ancient Greek philosophers about all the knowledge that we as humans have and the origins of this knowledge. Is it the case that all the things that an adult is able to do, know, recognize, and so on and so forth are things that somehow we already have in us, with us when we are born, and they just take time to develop, pretty much as the whole body sort of starts out from a basic plan that is already encoded in our genetic endowment. Or is learning, including the learning of language, culture, scientific knowledge, or all of the kinds of things that we pick up during development, are things that really are not biologically determined, and it really is experience that plays the most part. And so in the first case, if there's a larger biological contribution, then certainly we expect human development to be rather continuous. So there's no major gap or difference between adults and infants and children. If the opposite is true, if development is more based on learning and experience, then it could be the case that indeed there are some key experiences, key learning opportunities that need to happen, need to take place. And so in this sense, there is a before and after. So adults and children or infants might be radically different depending on whether they had or what kind of experience they had. So this is this sort of major big philosophical question why it's interesting to look at infants to begin with. So try and understand where human knowledge is coming from. And of course, if we find, the more we find that infants are able to do the same kinds of things that adults do, then the more it is likely that somehow our knowledge or parts of our knowledge are somehow genetically or biologically endowed. The more we find differences, the more likely it is that learning and experience play a role. Of course, the way I put it is, in a certain sense, almost caricatural. That is, obviously, both biological genetic factors and learning and experience play a role. And really, what's important is to tease apart what kinds of mechanisms are at stake or are responsible for what kind of aspects of human knowledge and human development. And so underlyingly, when we ask this question, we also ask, one could ask about just knowledge in general, but of course, we know what supports human knowledge, and that's the human brain. And so using brain imaging allows us to actually answer this question at the level of the neural structures underlying human knowledge. So is there continuity in the development of the human brain? And what are the properties, or how can we characterize the brain at different developmental stages, starting from birth all the way to adulthood? And so if one is going to use brain imaging to address these issues about the brain and ultimately about human knowledge, why would you use NIRS, and how can you use NIRS in helpful ways? People in developmental neuroscience have been taking two different approaches, sometimes complementary, sometimes really just one of the two. Some people are interested in using NIRS because they are interested in learning about the brain. What they really want to study is brain development. And so NIRS is one of the imaging modalities that you can use to document certain functions or certain aspects of brain development, how they change over time. Another possibility, again, not exclusive of the other, is to use NIRS and brain imaging to study the functions of the brain. So essentially, all the human knowledge, the abilities, skills that we have, and to study not just the behavior. So if I'm interested in reading, I could just test how children read. Or I could, while doing that, I could also look at how their brain actually produces this function, and what are the mechanisms that allow children to then perform a certain task. And so, so these are the two possible ways in which NIRS or any brain imaging data could be interpreted. So these, as I say, are complementary. Of course, the more we know about the brain, the more we can also inform research about behavioral questions, or the other way around, if we are really only interested in behavioral outcomes, yet we have imaging available, then we have simply more information, more data, and of course, obviously, the two things should go together. But nevertheless, I do want to mention that especially with infants, for multiple reasons that I will explain in a second, some researchers, or many researchers, tend to take a stance where they use NIRS as if it was a behavioral measure in a certain sense. So this is the approach that I like to call the brain as a black box. So essentially you use NIRS to get some measure of cognitive processing, say a difference between two conditions, and all you care is whether you find a difference or not. And you don't try to understand or interpret particularly strongly, at least, what the actual underlying neural mechanisms are. This is often done in developmental studies because we know much less about the infant brain than we do about the adult brain. So very often, even if you wish for sophisticated neural explanations, and of course, NIRS is something that you can really use that for, simply there's just not enough knowledge available to have as precise interpretations of the data as one could sometimes wish for. Nevertheless, taking an experimental approach means that you manipulate one single feature in a task and you compare two conditions, typically with and without that feature of interest. And so you can establish a causal relationship between some outcome, in this particular case, the hemodynamic response function, and the manipulation that you're interested in, so the presence, absence of a certain feature. And so this is true even if you don't actually know exactly what brain mechanisms are really responsible for these outcomes. And of course, then NIRS can help you to try and find these out. Okay, so this is all very exciting and interesting. NIRS really is a great opportunity to look at infant brain development. But at the same time, when one chooses an imaging modality, for example, how to spend grant money and what machines to buy, or even if many machines or techniques are available for any specific study, when one wants to decide how to plan a study, but one needs to take a decision about what modality to use. And of course, in this particular case, what we are interested in is why one should use NIRS. So this is a figure where there are three important dimensions. This dimension here, so the y-axis, indicates the goodness or the preciseness, precision of temporal resolution. So how fine-grained the measure is in time of a given imaging modality. The x-axis indicates spatial resolution, so in terms of brain localization and space. And the third dimension, and this is particularly relevant for today's talk, is the degree of tolerance by infants. And this is also color-coded. So if you see red or darker colors, reddish colors, represent sort of the further end of this dimension, that is modalities or techniques that are not very well tolerated by infants. So if we now focus for a second on this dimension, then we see that among the imaging modalities that are represented, NIRS and EEG are the ones that are particularly comfortable and easy to use and well tolerated by infants, whereas other modalities, MEG, PET, MRI, DIT, have all our sort of complications for one reason or another, sometimes safety concerns, sometimes just simply problems of motion, and so on and so forth. So but if one wants to do an infant study, then the most obvious techniques to use are NIRS and EEG. And so these two techniques are similar in terms of how well infants tolerate them, but they of course have important differences in the other two dimensions, in the spatial and temporal domains. So EEG measures, it directly measures the the neural activity. So it's temporal resolution, both of the machines, but also of the actual physiological responses, is extremely good. It's in the millisecond range. NIRS is less good in its temporal resolution, not so much because of technical limitations on the machines, but rather because of limitations on the physiology. So the hemodynamic response function is a relatively slow response. It's not the neural response itself, but rather it's hemodynamic metabolic correlate. And so given that this is the case, it takes several seconds to sort of start off and peak. The NIRS technique, at least if it's in its current form, is a relatively slow measure. But there are technological innovations and innovations in terms of data analysis, and we are getting closer and closer to really be able to do more sort of event-related and faster types of measures. Nevertheless, simply the physiology itself is slow, at least slower than EEG in the second range rather than the millisecond range. But one big advantage of NIRS, which makes it similar to MRI, is that it has a precise spatial localization. Of course, its resolution is absolutely not as great yet, at least, as MRI, which now is in the sort of millimeter range. But importantly, localization using NIRS is precise. So if you measure hemodynamic response in a specific localization, in a specific spot on the surface of the head, then you know that the response you're measuring comes from underneath that measurement area. There is no inverse problem, like in EEG, right? The problem is that the electrical activity of neurons propagates throughout the head. And so in EEG, whenever you pick up a signal, you actually don't know where it originated from inside the brain. This problem is not present in NIRS, so localization is precise in this sense, or straightforward. The resolution, of course, is somewhat less good as MRI, but the technological development is such that there is an improvement or increase in spatial resolution as technology advances. Okay, so this is just another type of summary of comparing EEG, NIRS, and other techniques for specifically for infant imaging. So the resolution issues we have already discussed. I would spend some time on the non-invasiveness. So this is somewhat similar to the tolerance dimension that we discussed in the previous slide. So for example, MRI requires or uses a strong magnetic field. PET uses isotope tracers. And so other methods have MEG requires immobilization or sedation. So the other methods have some constraints that make it either not fully safe or at least not comfortable for infant participants to participate in a study, whereas EEG, and in particular also NIRS, are fully non-invasive. So much so that these are actually measures, and NIRS in particular, that can be used even with the sort of youngest, most vulnerable preterm premature infants. So actually NIRS is one of the techniques of choice that are used in these very tiny, tiny little babies born 2-3 months prematurely, whose physiological functions are extremely, extremely immature, sometimes weak, and maybe sometimes even pathological. Yet NIRS is a technique that they can easily tolerate. Another advantage of NIRS is its relatively low cost. Unlike, for example, MRI, where both the machine itself and its operation are costly, in NIRS, the machines, of course, vary a lot in their prices, but it's still in a more affordable range, and then subsequent operation is really not particularly expensive. Another huge advantage for NIRS is what we usually call bedside applicability, but really in general, it's portability. So that means that NIRS can easily be used and set up outside of the laboratory. For clinical applications, it can really be just stationed next to the bed of a patient for long-term monitoring. But what has been also done recently quite a lot in the developmental NIRS community is that NIRS can be taken to the homes of the participating infants, even as far as rural Africa, Bangladesh, and other areas where there are no laboratory facilities, but actually all one needs is a source of electricity, and NIRS is easily portable, transportable, and can be used in the homes. This is also related to the next point, which is that NIRS is relatively easy to apply and operate. So capping an infant is not particularly difficult. And in general, to operate NIRS machines can easily be taught or trained in a few easy steps. So either large-scale operations are possible where many participants are being tested at the same time or in a short time scale by many operators who are just trained specifically to get the machine working. Or, for example, one consideration that's quite important for research is that it's not difficult for newcomers, so say undergraduate, graduate students, to be trained on NIRS and start to acquire data. So as we know, time is never sufficient, and there are different deadlines and other time constraints. PhDs need to be finished in a certain time frame. Postdoctoral researchers need to apply for jobs and so need to acquire data fast, and so on and so forth. Luckily, the learning curve of NIRS, at least in terms of getting everything ready and starting to acquire data, is quite easy. And so another important thing that is actually important from my point of view, because I look at the acquisition of language, and so language is, at least for infants, primarily an auditory modality. NIRS is a silent technique. So while MRI has lots of, it's a very noisy environment, given the magnets and the coils it uses, NIRS is completely silent, so it's very well suited for the presentation of auditory stimuli. And a last factor that is particularly important with infants, is really a huge issue, is that NIRS is relatively motion tolerant. So infant participants are challenging. They cannot be told to stay still or not to move, and so infant data can be corrupted by motion artifacts, and this is a huge problem in general in any imaging modality. And NIRS is relatively tolerant with respect to this, definitely more than EEG. And one particular experience I have is as long as the cap remains in the same position with respect to the head, the hands or the legs or the whole body can move relatively freely, which is not the case in EEG, which of course picks up on muscle motions and in general any motion artifact. In NIRS, there are motion artifacts related to when the cap moves with respect to the head, but if the cap is well secured, and this is a crucial point in infant research, then once that is fine, other movements are well tolerated. So this is, I think this must be quite obvious for most of you, and certainly has been covered in a lot of the webinars so far, but I want to sort of put the whole thing in context. And before I tell you about applications of NIRS with infants, I want to also draw your attention to applications of NIRS in general. And so, of course, the reference in a certain sense is always adult work. So when is it, how is it that people use NIRS with adults? It is often claimed or said that NIRS with adults is a niche technique. So in adults, one can often use other techniques that are either more invasive or more complicated, and often have a better spatial or temporal resolution. So in adults, one can do MRI for a better spatial resolution, or EEG for a better temporal resolution. However, and this is where the idea of a niche comes from, some of these techniques are not compatible with certain situations. And so this is when NIRS comes in really handy. As I said, NIRS is relatively motion tolerant, and so neither MRI nor EEG allows participants to behave, perform a task, or move, whereas this is quite compatible with NIRS. So some examples include athletes who are or just in general sports science and motion science, even just walking and gait, where sort of the underlying neural mechanisms can be studied in athletes or people who actually perform physical activity. Or one of my favorite sort of applications in adults is that you can put NIRS in the cockpit of an actually flying plane and measure the cognitive load in pilots. There are several laboratories that do this. One in particular in France, people I have collaborated with, they really do take NIRS up in the air, cap pilots, and then look at situations where pilots actually make mistakes or take the wrong decision, typically out of problems integrating visual and auditory information, or all sorts of different information coming from different modalities. In these situations, so this is the human error in aviation, it is very important to better understand what are the neural mechanisms that make pilots make mistakes. And without brain imaging, this is quite challenging. NIRS is a really optimal solution for this. NIRS is also a technique, as we mentioned before, that allows bedside monitoring, which again is not possible with MRI, and somewhat complicated with EEG given the motion artifacts. So it's stroke and coma patients. And finally, very sort of fashionable and sort of sexy applications are brain-computer interfaces, precisely because NIRS is tolerant of motion artifacts and allows participants to move a little bit or perform tasks. It is possible for people to, say, move their eyes or move their fingers in order to then, for NIRS to then register their brain activity and use that as some sort of information. So, for example, patients in coma or locked-in syndrome can make, they are conscious but can't move in any way to express their thoughts. NIRS, or brain imaging in general, has been used for that. So these are special situations. In adults, we see that NIRS is often, not exclusively, but often used as a niche technique. This is not so much the case in infants. In infant research, there is really a large, very broad spectrum of the types of applications that NIRS has. So NIRS is really one of the methods of choice combined with EEG or as an alternative to EEG with typical infants, newborns, and infants for a number of reasons. One of them is that the behavioral repertoire of infants is obviously limited. So while in adults you can ask them to perform a task, this is not the case in infants. They will not follow instructions. You can't just ask them to do many things. They can't even reply. Their spontaneous behaviors are limited too. So in a certain sense, since their behavior is so limited, it's more useful to go directly in to see their brains, and so NIRS allows you to do that. And there are also special infant populations where certain features of NIRS are very useful. So as I mentioned, the non-invasiveness of NIRS is a very useful feature for monitoring the oxygenation level in the brains of premature newborns. One of the main problems or main issues of prematurity is precisely that these premature brains do not get enough oxygen because of the immaturity of the lungs and the vascular system. But of course, this is the issue that has possibly the worst developmental outcomes or long-term consequences. So brain oxygenation is key to the healthy recovery or survival of premature babies. And so monitoring their brain oxygenation using NIRS is a very important clinical and research tool. Another thing that I would like to mention, simply because this is something that I'm interested in, but also is a very important application of NIRS in infants and also potentially in adults, is cochlear implant users. So this is a technology to augment or overcome hearing problems that is quite specific in that cochlear implant users have a small computer built-in, implanted into their heads under the skull. And so this makes them incompatible with MRI because they have metallic pieces inside their bodies, so they can't go into a magnet. But also with EEG, because simply the processor of this computer interferes too much with the EEG signal acquisition. NIRS has absolutely no incompatibility. So I myself have been doing research with cochlear implanted infants, and this is in general an area where NIRS can be extremely helpful and allows to do something that no other imaging modality does, namely to look at the brain of deaf infants before and after implantation and see how hearing and language abilities improve after once the children are implanted. And finally, autistic participants are another population where NIRS research has been particularly important. This is also related to the limited behavioral repertoire of many autistic participants. Some people with autism are nonverbal, so either they don't understand or at least don't understand language and so don't comply with instructions. Or even if they do, at any rate, they cannot give verbal answers. So it's harder to test them in behavioral tasks that require linguistic communication, whereas very often a passive task, watching or listening to some stimuli while they're wearing a cap and there is no human experimenter involved, is something that they are often more willing to do. Okay, so another issue that is related to why and how to use NIRS in infants is the physiology or the anatomy of infancy. So we have, as I just mentioned, NIRS has lots of applications in infants, and one of the reasons why NIRS is a lot more popular with infants than with adults is that one can get a really good signal in a certain sense from infants, despite motion artifacts and other non-compliance problems, because simply their tissues are thinner. So what we're interested in is looking at the brain, but of course the brain is inside the skull. So for any brain imaging, and in particular for optical imaging for NIRS, there is the problem of how much one can penetrate into the skull to see the brain, rather than tissues that are above. So the bone, the skull, but also other tissues. And so in infants, these tissues are actually thinner and their heads are smaller. So the technology, NIRS, is better suited to query or explore the brain at greater depth. So penetration into the cortex is deeper, meaning you see more brain tissue than you do with adults. So to sum up, NIRS is really well suited to test infants for a number of its features that we mentioned. Another important consideration, which is probably very clear for everybody, but this is something that comes up very often nowadays in research: safety. So for obvious ethical reasons, it's very hard to use an imaging or other experimental modalities that are unsafe. And of course, even once you have ethical approval, parents themselves often worry or ask researchers these questions. And so I thought it was useful to mention that measurements have, of course, been made to see how NIRS, in particular near-infrared light, interacts with tissue. And so what are the potential dangers of NIRS? And so what near-infrared light does with tissue is light in general, in particular infrared light, does is communicate heat, energy. And so what you see in this figure is how much change in temperature can be measured when a given location on the head is exposed to near-infrared light. So imagine that this is the surface of the head, so the skin and the scalp here, and this is penetration depth into the head, and this is distance in radius, of the radius, sorry. And so this is the cross-section, essentially, of the head, and near-infrared light of a given power, so 10 milliwatts in this particular case, is projected onto the head from a near-infrared source. Then what you can see is that there is a change corresponding to about 1.2 degrees Celsius, so very, very little, at a penetration depth of less than 0.23 millimeters. So essentially, this is the very, 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 very outermost surface of the skin that heats up, say, about a degree Celsius. So this is less than putting on a warm cap on a child, or what they often assimilate this to is walking outside in the street on a cloudy day. This is the strength of the sunlight that you receive on your skin when you walk outside on a cloudy day for about the same time as the NIRS measurement itself. That is to say, there is very little heat communicated to the tissues, so this is absolutely not damaging in any sense whatsoever to the infant head, and the heat that is communicated does not reach the cortex, the brain itself. The only effect it has is to heat up the skin a tiny little bit, so it's perfectly safe. Right, so this is about the advantages of NIRS and why it's a great technique to use with infants. Now let's come to some of the challenges, which are not so much related to NIRS itself, but rather to infants in general. So infants have a low attention span, so when we run experiments, typically we cannot count on more than 5-10 minutes of compliance. The only exceptions are newborns, who are typically asleep when we test them, so we can test for somewhat longer times. As we mentioned before, infants are nonverbal, and so they have a hard time understanding instructions. Actually, they don't, and even harder for them to comply with these instructions or give responses. And so as a consequence of these things, experiments are short, meaning that you acquire less data, fewer trials. There's also some risk of poor data quality due to movement artifacts, as we discussed, and sometimes also hair. Not so much, so infants typically have less hair than adults, But the problem is that while in an adult, you can spend time removing or simply arranging the hair in a way that it doesn't interfere with the contact between the sensors and the scalp. Infants are not very patient for these kinds of things, and so you really need to cap them quite quickly. There's no time to part the hair or arrange it in a way that is helpful. Another issue that is very frustrating for most infant researchers, even doing behavioral work, but of course with imaging it's even stronger, is that infants start crying, or they just lose attention and stop sort of collaborating. So you're not able to collect sufficient data from them, and definitely not enough to enter them into the final sample or the full analysis. And so this is what we call attrition. Attrition rates can be pretty high in infant studies. Another thing which I will illustrate in the second part of the talk is the variability of the hemodynamic response function in infants. So theoretically, we know the hemodynamic response function, and even empirically, we know the hemodynamic response function well in adults. There is an increase in oxygenation and a decrease in the concentration of deoxyhemoglobin in the blood flow in response to a specific stimulus. And so in theory, this is also what the infant hemodynamic response should look like. But in actual practice, we very often find inverted responses. So when deoxyhemoglobin increases and oxyhemoglobin decreases, or other variations. And so deviations from the canonical pattern. And so this is, of course, very challenging to interpret. Already from a physiological perspective, it's very hard to say why this is the case. And then it's even more difficult to draw appropriate theoretical conclusions. So to answer your research question becomes really tricky if the measured hemodynamic response is not canonical. And this then makes data analysis more difficult. I want to show you a few pictures now of what it really looks like to test infants before we go on to the studies. These are pictures from my own laboratory. So what you can see here is a newborn infant in the baby's hospital crib. So we test them while they're asleep, or at least quietly resting in their cribs. And all we need to do is cap them, and then if one is lucky, then they go through a fair amount of time sleeping, and we are delivering auditory stimuli. So they're listening to linguistic stimuli, and we measure their brain responses. And so here you can see the fibers. These are the detectors and the light sources. So this is an older version of the NIRx machine that I'm using in the hospital environment. And so this is a very similar cap, but now on an older infant. This is a baby from our laboratory tested at 6 months. So as you can see, kind of in the background, a caregiver is sitting, and the child typically sits on the caregiver's lap, or in some laboratories, the child sits in a high chair, and the caregiver is somewhere by the side or behind the infant. And there are different ways in which, first of all, for capping, we typically entertain the child blowing bubbles. Babies, of course, love soap bubbles, and this distracts them from resisting, opposing, and crying when we try to cap them. Most babies don't like fiddling around with their heads, so capping is a really important but very difficult part of the whole experimental process. And so first, for us, for the experimenter, capping needs to be as precise and as well done as possible. At the same time, there is very little time for this because, as I say, babies hate this. And so if they start to cry or fuss out, then very often we just cannot go on with the study at all, and no data is collected. So it needs to be fast but accurate. And of course, this is a challenge. So blowing bubbles or playing music from an interesting toy are tricks we use. Now, another thing that I wanted to show is the screen that we have here that you can see in front of the infant. Typically so it is possible, of course, to simply test visual stimuli. I myself work on auditory stimuli and language. So what we deliver are sounds, but sounds are boring. And so typically we project some sort of interesting movie, a cartoon, or some other attention getter for infants to stay focused and happy throughout the task. Okay, so this is my own daughter, happily already older, so not a 6-month-old, but maybe about 1.5, happily eating cookie and wearing the NIRS cap for the sake of the photograph. And another thing from my laboratory is you see again, this is a doll, not a real baby this time. You see the same setup as before in the hospital crib. And this illustrates how NIRS and EEG can be co-recorded. So as some of you might recognize, these are the NIRS optodes, but in the very same cap, one can also introduce EEG electrodes. And so using the exact same headgear, it is possible both in newborns or a doll model of a newborn and in a real baby to easily integrate NIRS and EEG, at least from the perspective of sort of logistics and technology. They are easy to integrate and the two signals don't interfere. It is much more challenging to actually find stimuli that are appropriate because, of course, as we said, EEG is fast, NIRS is slow, so it's very hard to set up an experiment or stimuli that are both slow and fast at the same time. That's a whole sort of different discussion to have, but at least technologically speaking, it is easy, even in infants, to integrate NIRS and EEG into the same headgear. All right, so I will now go on to illustrate the variations of the infant hemodynamic response and in general how to conduct and interpret NIRS studies with infants through two experiments from my own laboratory. So the first study will be, this is one of my first NIRS studies ever. And I was lucky enough to actually find what I will call the canonical hemodynamic response function, so an increase in oxy, decrease in deoxyhemoglobin. So this is going to be an illustration of when things go exactly as planned. So in this particular study, we wanted to look at how infants can learn regularities, rules, grammar, if you wish, rules of language. This is, of course, a key issue in language acquisition research. And of course, if you have ever studied a language consciously, so in a school environment or some sort of educational environment, then you know that these are the really difficult things to acquire. Because yes, so this is the things that we struggle with as adults, but babies actually pick up rules of grammar very, very easily. And one theoretical question that people have been wondering about is how young is it? When is it that they can start learning about the rules of grammar? So we wanted to be ambitious, and we thought, well, what's the earliest we can test? The earliest we can test is birth. So remember the initial theoretical discussion I had. We know that older infants, toddlers, and children are really good at learning the rules of grammar. Indeed, they learn their native language very fast. And there is this question of continuity. Do we find evidence that from the get-go, from birth, infants are able to do that? So we wanted to push this question all the way to the youngest age. So we tested newborns. And so we devised an artificial grammar essentially a mini language that produces two types of structures. One structure that I will call ABB. And so this structure is such that there are sequences of 3 syllables, as you can see here, talulu, benana, where the second and third syllables are identical. So this is this repetition of BB that you see here, talulu, benana, and so on and so forth. And we created another grammar that is very similar, ABC. The only difference is that now here there is no repetition. The second and the third syllables are different. They're not identical. But as you can see, these are roughly the same syllables. They are very, very similar. Talulu has a repetition, and it has an equivalent talupi, which has no repetition. But of course, the beginning, as you can see, is really the same. So these two types of sequences, apart from the identity of the third syllable here, are really exactly the same. And so we presented these two grammars to newborns in what I will call a block design. So here, this is what I will call a block. Within a block, you have 10 little ABB words. So say talulu, penana, mofafa, and so on and so forth. 10 of these words, all different, separated by silences of varying duration. And so in one block, there are 10 of these. And there are two types of blocks in the experiment, ABC blocks and ABB blocks. And also, of course, in the ABC blocks, there are 10 little ABC words. And for each of the two conditions, we had 14 blocks. So here you have one block, and imagine 14 of these with all the words always different. So no one word was ever repeated. So all the blocks of the same grammar actually contain different words, but these words all shared the same underlying structure, either ABC or ABB. And our question was whether newborns can tell the two apart. So this is a type of grammar learning because they have to distinguish between two different patterns, a repetition pattern and the lack of the repetition pattern, if you wish. So what we really use NIRS for is to measure the difference between ABB blocks and ABC blocks. And this is how we place the probes. Red dots are light sources. Blue dots are detectors. A channel is, of course, this coupling of the two. We had 12 channels per condition on each per hemisphere. And as you can see, there are regions of interest that we knew should be activated by language and auditory stimuli. So here what we find is the temporal areas of the brain. These are responsible for auditory processing, so processing sound. And of course, we delivered our grammar as sound. And here, the inferior frontal areas are where structures, in adults at least, are structures where that are responsible for processing grammar. So for example, the famous Broca's area. So we covered these areas and a lot more. So we covered really the two sides of the head. So for at least a small newborn head, these 24 channels provide quite a good coverage. And so I will skip now the details of the data analysis, but we had a really simple data analysis using essentially an averaging method, meaning averaging across blocks of the same condition. So more like an analysis method inspired by EEG, where each individual response is not looked at independently, but rather responses of the same condition are averaged together. And so here are the results. This is a very complicated slide, so don't worry, I'll take you through the slide. So first of all, remember the channels from the head model. So if I go back here, then say this is channel 3 here. This corresponds to channel 3 here, right? So the layout is the same as in the previous image. So the ear is somewhere here and the nose is looking outwards. Same here, the ear is here, the nose is looking outwards. And so we have the 12 channels per hemisphere. This is the left hemisphere. This is the right hemisphere. Now, in each channel, what you see in the small plot is the grand average response. So this is averaged across infants. And as I just mentioned, averaged across blocks. So for all the blocks of the ABB grammar, so the repetition sequence, all 14 blocks are averaged together into this one hemodynamic response. And so the pink dashed line is the response to the ABB grammar. The red continuous line is the response to the ABC grammar. And what we're interested in, so red and pink, oxy, blue and turquoise, deoxy. And what we are interested in is the difference between the response to ABC and ABB. And what you can see on the x-axis is time. A block lasted about 18 seconds. So this is the duration of the stimulation. And this is concentration change on the y-axis. So this is really the hemodynamic response that you're measuring. And so what you see is the shape, the canonical shape of the hemodynamic response, an increase in oxy, a slight decrease in deoxyhemoglobin. It is very often the case, for example, here you can see it very well as well. It is often the case that deoxyhemoglobin is less responsive, so you see a higher amplitude response for oxy than for deoxy, and so for the same reason, statistical results are often based on oxyhemoglobin because simply it provides higher significance. But it is important for it's a good practice to actually include deoxyhemoglobin data, even if it's not significant, in all of the papers and report it, because precisely if only oxy is reported, one cannot know whether one is observing a canonical hemodynamic response with a corresponding decrease in deoxy, or say some sort of strange response where, say, oxy increases, but also deoxy. So this is important to clarify and report both oxyhemoglobin and deoxyhemoglobin. So for the research question, what you can see is that there is a huge advantage, a much greater response in a lot of the channels to the ABB repetition grammar. And in particular, in the regions of interest in the bilateral temporal areas, and also in mostly in the left frontal area, this advantage is statistically significant. So newborn infants did respond differently to the two types of grammars, suggesting that already at birth, human infants are able to encode some sort of structural regularity, which is, of course, the basis of language acquisition. Now, remember that these results are grand averages. So we averaged across all the blocks. So these are 14 blocks per condition. But one might wonder what happens throughout the whole experiment. And so for this particular area, which was where Broca's area is, so this is the area that's responsible for learning grammar and structure, what we did was sort of unpack the experiment and look at the response over time. And so as one can see, now the color code is different. So these are just oxy responses. One data point, the average under the curve per block. So you can think of this as time or block, and the two conditions are ABC and ABB. So the dark gray is the repetition grammar. And as you can see throughout the whole study, the advantage for the repetition is present. It gets weaker, there's a small fluctuation over time, but definitely from the beginning, the response seems to be greater, as you can also see as the average of blocks from 1 to 4 and the average of blocks from 11 to 14. As you can see, there is an advantage for the repetition grammar, and in particular, this means that there is a difference in how babies process the two grammars, meaning they seem to have the ability already at birth to learn about rules and regularities. So this is when everything goes well. You get a very beautiful canonical hemodynamic response. But this is not always the case. One is not always that lucky, And in some infant studies, people have reported inverted hemodynamic responses, so with an increase in deoxyhemoglobin and a decrease in oxy or other shapes. And so I'm going to tell you how we dealt with that in one particular study that we had in the laboratory that had this. So the theoretical question here is very different from the previous one. We were interested in how temporal information in speech is processed. So speech, and in general sound, unfolds over time. And so temporal information is crucial, and there is both variation in this. So some people speak faster than others, for example, and there is invariance. So I might say the same sentence once slowly and once very fast, and you will be able to tell them apart. One will be longer than the other. At the same time, you will also recognize that I said exactly the same sentence. The linguistic content remains invariant. So what we were interested in is how babies deal with the perception of time in speech and whether they're able to extract invariance despite variation in time. So essentially, what we did was to look at time compressed speech. So this is a paradigm that we did not come up with. This exists. People have been looking at how participants perceive speech at a normal rate, and then the same sentence compressed in time, so speeded up to, say, compressed to 60% of its original duration, so a bit more than half of its original duration, or very, very fast, 1/3 of its original duration. And so in adult research, so this is precisely kind of, as I said, it's not a new paradigm. There has been a lot of work going on with this. Adults are quite good at adapting to time compressed speech. So they tolerate compression up to about 40% of the original duration. So you understand speech if it's accelerated by twice the speed or even a little bit more. And this is interesting. It happens at a level that is not particularly linguistic, because one can do this in one's native language, or a language with which one is familiar. But interestingly, people can also do it in unknown languages, as long as these languages are, they sound similar to languages that they know. So say Spanish speakers can adapt to compressed Spanish, but also to compressed Italian, for example. So this adaptation, so this suggests that this adaptation happens at the basic perceptual auditory level, and it doesn't involve the knowledge of language. So if you're a Spanish speaker and can do it for Italian, although you don't speak Italian, then it suggests that the grammar or the vocabulary are not involved. So theoretically, newborns could also do it. And so this is exactly what we wanted to find out. Is it really the case that this is a general ability of the auditory system, and you can normalize for or compensate for changes in tempo? Or is it something that people know how to do because they have a lot of experience with language? So it could be the case that a Spanish speaker can adapt to accelerated Italian, and that means that the grammar and the vocabulary of Italian are not necessary. But maybe just generally the fact of having experience with speech and language, even in a different language, is relevant. So in that case, newborns should not be able to do it. So we wanted to test this. And what we did was take child-directed speech. So essentially the kinds of short and very intonated sequences or speech that people use when talking to babies, especially in North American English. Hello, baby, how are you? Is the type of thing that we use. This is simply because babies really love this and they respond a lot to this. And so what we did was exactly what you saw 2-3 slides back. So we took different sentences like this, and then we compressed the recording to 60% and 30% of the original duration. Remember that adults can easily understand the original one, but also the 60% compression. But adults have a hard time understanding, or they cannot really understand 30% compression. So remember that. Okay, and so we did the same. We tested these babies on 100%, 60%, which we expected that if this is an ability that requires no experience with language, then newborns should be able to do, and maybe 30% will be too challenging for them. We also used a block design, but in this particular case, it was a tricky one. We did not use simple blocks. We used what's called an alternating, non-alternating paradigm. So in some blocks, take this one, we only had sentences that were compressed. All of this was compressed speech, different sentences. These were the non-alternating blocks. But in other blocks, so this is an example of that, which I will call the alternating blocks. Here we had compressed and non-compressed sentences mixed in together. This is non-compressed, this is compressed, non-compressed, compressed. And so the logic behind this is that if babies can discriminate compressed and non-compressed speech, then blocks like this, the non-alternating ones, will sound really different than the alternating ones. And remember, in the non-alternating ones, we had both blocks that were compressed and blocks that were non-compressed. And also, as I mentioned, we used 100% non-compressed and 2 levels of compression. So in half of the experiment, we presented 60% compression, the one that is understandable to adults. And another half of the experiment represented the 30% challenging one that we thought that newborns will not be able to process. And so we looked at 2 types of things. First of all, the difference between non-alternating and alternating blocks. This indicates discrimination, whether can tell the compressed and non-compressed blocks apart. And also we looked at pure processing. So how do they process non-compressed speech? How do they process 60% compressed speech? How do they process 30% compressed speech? And again, the same illustration you saw before. So this is a participant in our setup, a baby quietly sleeping in her bassinet at the hospital. And the probe placement is again the same as before. So as always for language, we are interested in the temporal and frontal areas of the brain. And here are the results. So I'm first showing you the non-alternating blocks. So this is pure processing. How do they process 30% compression? So this is the difficult condition. This is the continuous red line. 60% compression, which is understandable for adults. So this is the dashed line. And then non-compressed or normal speech, which is the dotted line. And so what you can see in many of the channels is that we get a canonical response to normal and 60% compression, and the negative inverted response to 30% compression. So it seems like, similarly to adults, newborns respond to normal speech and 60% compressed speech similarly, the same as adults. Adults understand 60% and 100% compression, so no compression. But they process, both the newborns and of course adults, they process this challenging 30% compression in a very different manner. And so this is just the same illustrated now as bar graphs. And the responses to 100% and 60% are canonical. So oxy increasing, deoxy decreasing a little bit, not changing much. Whereas the responses to 30% compression are inverted. deoxy increasing, oxy decreasing. So this suggests that newborns, like adults, are somehow able to adapt to compression up to a certain level, and this seems to be somewhere between 30% and 60%, just like for adults. Now, this is the comparison. So remember, the responses to 60% compression and 100% compression seem very similar. Is it the case that they don't realize that this is compressed, or is just that processing is similar, but there is discrimination? And so this is what comparing the alternating and non-alternating blocks gives you. So if when we look at the half of the experiment that contained no compression and compared it with 60% compression, then you see that there is an advantage for the alternating blocks in many of the channels. So even though the processing of 60% compressed speech and non-compressed speech in itself is similar, it is not the case that babies cannot discriminate them. They still perceive them as being different, as the responses to these two types of blocks suggest. Okay, so let me just sum up what we have learned from these experiments and in general from the presentation. So from infants, even the youngest ones, newborns, one can obtain a canonical hemodynamic response. So NIRS works pretty well with these babies. You can get nice responses, but the hemodynamic response might be variable. To begin with, it is somewhat different than the adult hemodynamic response. Typically, it's slower, so it takes longer to peak, often plateaus for longer, and takes longer to go back to baseline. And when you find an inverted hemodynamic response, it's really unclear very often what you can attribute it to. Some people claim it's simply immaturity of the brain, but of course, remember, in our experiment, we got a canonical response in 2 conditions and an inverted one in only 1 condition. So we cannot claim that this is due to immaturity because the same brain produced both a canonical and an inverted response. So of course, if it's in the same baby, it cannot just simply be immaturity because this is clearly a brain that is capable of producing a canonical response. But in some cases, it might be an immaturity, depending on the research question. For speech perception, at least the perception of time-compressed speech, this wasn't the case. It can also be due to the experimental task, and this is what we find, right? So in our particular case, in some conditions, the response is canonical, and in another condition, it's inverted. So we do think that inverted responses can be genuine, true responses of the system. For example, in this particular case, it might indicate some sort of failed processing effort. So 30% is not something that the babies can process as linguistic stimuli, like adults cannot either. And so there is a failed processing attack. And so I would like to leave you maybe with these review papers, some of them very basic and sort of foundational papers of NIRS, but in particular, these later ones are all developmental papers. So these are papers that summarize different aspects of using NIRS with babies, either from a methodological perspective or from a clinical perspective, or looking at sort of the literature or reviewing the literature from a more general point of view. Thank you very much for your attention.
Okay, thank you so much for that, Judit. Really, really appreciate that excellent talk there. And I'd like to also introduce here Dr. Mahipal Chaudhary, NIRx scientific consultant that has been fielding questions and looking over everything. He will be now presenting those to you, Judit. And I'll leave it now to Mahipal and yourself, Judit. Thank you again.
Thank you.
Thanks, Thomas. And indeed, thanks a lot, Dr. Gervain, for sharing this fascinating knowledge with this. Lots of kudos and thanks from the attendees. So that's always a good sign. We'll try to go through as many questions as possible, but if we miss any due to time constraints, then for the attendees, please write to us and we'll get back to you. Okay. First question we have is, in small babies, how do you prevent experimenters from influencing babies when they hold them?
Right. So this is, of course, a very challenging thing, and it applies to not only NIRS, but anything else. So the typical, there's typical procedures. One is that, first, as you could see, the older infants are held by parents who are not aware of the research question. So while they might see or hear the stimuli, they are not aware of what you're trying to measure. But of course, the good practice is beyond this is even to blind them. So if the stimuli are visual, to make them wear dark sunglasses or make them listen to masking music, and the same for the experimenter. So this is a very classical procedure of blinding either the caregiver or the experimenter. So whatever channel is used for delivering the stimuli, auditory, visual, or something else, make the stimuli unavailable to whoever adult is handling the infant.
Okay, right. Question number 2, how much does the signal penetrate in case of infants as compared to adults?
Right, so of course this depends somewhat on head size, so age, but in the best case, in newborns, let's say, we have a penetration, usually we say, of about 1.5 centimeters into the whole head, out of which a few millimeters are irrelevant, so skull and other tissues. So we tend to think that we see the gray matter in very small babies. So newborns, we definitely see a good part of the surface of the brain, so in particular the cortex, so the gray matter. We don't penetrate the white matter.
Follow-up question from me, does it differ between the prefrontal and the rest of the head? Depth of penetration?
Right. Yeah. Definitely. So of course, the brain is at a different distance from the scalp surface at different parts of the head. So prefrontal, frontal is great. Temporal auditory here that we test, so around the ears, is also a really great place to test. The curvatures of the head are trickier because, first of all, those are more variable across participants. And of course, because of the curvature, there is less good contact with the optodes, and potentially the brain can be further. What is more challenging, I think, is often the occipital area.
Okay. Right. I think you have covered this to some extent. Third question is, I'm particularly interested in constraints related to older infants from 12 to 16 months.
All right. Yeah, so the older they get, the more challenging it is. There is this sweet spot between, say, 6 and 12 months where they don't yet walk, so they don't want to run away from the experiment. They don't have that much hair. Their movement repertoire is more limited, but they already can stand still enough. So the younger ones, like say 4 or 5 month olds, have a more jittery, jerky movement, and so that can cause artifacts. So the sweet spot is between 6 and 12. Above 12, it's always possible to test, and in a certain sense, it's up to the experimenter to be tricky and find interesting attention getters and set up experiments that are engaging, but it's definitely a lot more challenging once the infant is able to walk. And so typically from 12, between 12 and 18 months, most infants start to walk, and so it becomes more difficult, but although still possible. And then from 18 onwards, it's even more difficult until about 3-4 years, at which time you can already instruct them and tell them to sit down.
Yeah. Okay. I think we have time for a couple more. In the time compressed experiment, what was the amount of time exposed to speech equal in both types of blocks? That is alternating blocks and non-alternating blocks.
Yeah, so it is true that due to the, sorry, this keeps coming in. So what we did was we kept block duration constant, or roughly constant, so roughly about 18 seconds across all the different blocks. But of course, the price we had to pay was that there were more sentences of the compressed type than of the non-compressed type in those blocks that contain non-compressed speech. So there are two ways to do it. One is, of course, to keep the number of sentences the same, in which case the compressed blocks would be shorter. We decided not to do that because actually in babies, the NIRS stimulus is very sensitive to just sheer amount of exposure. And so we kept the block length the same at the price of having a few more sentences.
Mm-hmm. Mm-hmm. Okay. Let me get the next one. In your opinion, I think you also covered it to some extent, but maybe you can summarize once more. In your opinion, is it valid to use the canonical HRF as a basis function in SPM, keeping in mind that its shape may be different for infants and that this aspect hasn't been studied in detail?
Yeah. So maybe there's one approach that we have been using is to use some of the data. So for example, babies in which the data is of really good quality, or even the whole data set, to average and create a hemodynamic response shape that is characteristic of that data set, and then use that in a GLM.
Mm-hmm. Okay.
Or at least anyway, model a few parameters of it, so the latency or something from to do it from a bottom-up data-driven way. So one can use one's own data to kind of drive the shape.
Okay. Related to the same question is it possible that the high heart rate in newborns be a cause for obtaining variations in HRF when compared to adults, for example?
Right. So we actually filter this out. So the good thing about heart rate is that it's relatively, it's well known. The frequency of it is well known and relatively stable. And so it's about above 1.2 hertz, even higher in young babies. So it's faster than in adults. And whereas typically, if you look at these blocks are so long that the frequency of interest, so the frequency with which our HRF keeps coming back, is around 0.02 hertz. So there's a huge difference. And so it's relatively easy to filter out heart rate. But in a certain sense, to have the heart rate contaminate the signal is a good thing, because you know you're picking up real real responses and not, I don't know, some other noise from the environment.
As an indicator of good optoid contact. Then there's a question on data analysis. Are there standardized pipelines? Because I see different methods in different papers.
Yeah. So
do different analysis produce very different results as in MRI?
Yeah. So this is a real challenge. It's really one of the next tasks of the NIRS community. I myself am involved in different projects in trying to standardize. The Society for Functional Near Infrared Spectroscopy has a standardization committee. So there are attempts to do that. For the time being, there is no one standard analysis. I think that's actually justified, given that NIRS is a relatively new technique. The technology itself advances extremely fast. So just since I began my career, there has been huge changes in hardware. So it seems like we are not yet at the point where we can totally settle. And also people do use NIRS for different purposes. So clinical work, where absolute oxygenation levels might be crucial, is very different from research where you compare two conditions in a relative way and don't quite care about absolute values. So I think there's a reason why there has not yet been standardization. But of course, this is at the same time a drawback, because studies are very hard to compare. And so this is not only true of infant NIRS, but NIRS in general. There are attempts to go that way, but the good news, I think, and I have done it with my own data, is if you have a relatively good data set, so not particularly artifacted, not particularly noisy, then using different methods gives you roughly similar results. So I have participated in studies where we did analyze the data using averaging on the one hand, GLM on the other hand, different parameters for artifact rejection and so on and so forth. And of course, numerically, there will be differences, but from the perspective of, say, a cognitive research question, it was more or less the same channels that showed significant results at more or less in the same time windows. So qualitatively, they were similar, reassuringly similar.
That's good to know. Okay. Also related to this is if you could provide a general overview of the differences in pre-processing strategies between infants and adults.
Yeah, so this is, stay tuned. So we are at the Society for Functional Near-Infrared Spectroscopy is about to publish a paper that provides general guidelines for reporting NIRS, but also for analysis. And I myself, with Jessica Gemignani, postdoctoral researcher working with me right now, and formerly a data analysis at NIRx, we also have a paper hopefully coming out soon, testing different infant pipelines that we found in the literature. So there will be, in the next, I would say, 6 months, there will be publications addressing these issues.
Okay, we can take one more, which is specific to the tools you used, how to create the topography map you showed in your PPT.
Right, okay. So there is a publication by Sarah Lloyd-Fox from 2014 where they describe a procedure, a relatively easy one, of having, when you can, by having surface fiducial marks like the vertex or the Bayesian or other points, you can project those onto a 3D MRI structural anatomical image, and from there you can project down to the brain. And you can do this in all your participants, assuming you have the proper measures and photographs of each of your participants. And then you can say, well, this particular channel in, say, 85% of my babies is temporal, so I'm going to label this as temporal. This channel here is frontal in half of my babies, temporal in the other half of my babies, so I label this ambiguous, or I exclude it or something. So this idea of projecting fiducials down from a 3D anatomical image is what's easiest, because most of the time nobody has, so participants don't also undergo an structural MRI before or after a NIRS study, but that would be ideal. If not, you just use a generic image.
Yeah, absolutely. Okay, publication from Sarah Lloyd-Fox from 2014. Nice. I think we are right on time to end the webinar. Thanks once again for your time. And thanks everyone who joined. We hope to see you in our next ones. Bye.
Thank you very much. Goodbye.
Thank you, Judit. Bye.